Hi, I'm Dr. Ann Greider. I completed residency in obstetrics and gynecology at the University of Cincinnati in 1998 and have been practicing general obstetrics and gynecology in Louisville, Kentucky at Women First since 1998. Today I'm going to talk to you about sexual dysfunction. Intercourse is painful. What treatments are available? The medical term for painful intercourse is dyspareunia. Pain can be insertional or with deep thrusting, and it can occur only during intercourse or can last for quite some time afterwards. Sometimes we get in a cycle of anticipating pain and contract all of our pelvic floor muscles, which increases pain with insertion. This is called vaginismus. The treatment for painful intercourse usually depends upon the cause of the pain. Two common causes of painful sex that I see are vaginal atrophy and musculoskeletal tenderness. Vaginal atrophy occurs as the vaginal tissue thins and becomes more fragile. Not only is lubrication lacking, but also lost is the elasticity or the ability to stretch in different directions at the same time. Vaginal atrophy is a progressive change after menopause, but it occurs more acutely after the removal of the ovaries after hysterectomy. It's the removal of the ovaries, not the removal of the uterus, that causes the problem. Vaginal estrogen therapy is simple and easy, but must be continued or it will recur. Sometimes vaginal estrogen is needed to treat vaginal atrophy even when a woman is taking systemic estrogen, such as oral estrogen pills or a patch or a gel. Musculoskeletal tenderness contributes to most all long-term painful intercourse. There is no orthopedist for the muscles and the ligaments of the pelvic floor, so this falls to the gynecologist. There are specialized pelvic floor physical therapists that we work with to help women with the sensitive issues of musculoskeletal pelvic floor dysfunction. What is vulvodynia and how is it treated? Vulvodynia is chronic vulvar discomfort, usually burning pain, in the absence of visible abnormalities or a specific identifiable neurologic disorder. It's neuropathic pain, which is pain due to abnormal nerve signals that started with disease, irritation, or injury. However, the pain persists even when the injury or disease or irritation is long gone. Vulvar pain is generally diffuse, constant, and unprovoked, meaning that nothing specific may cause it to start hurting. Patients have a hard time describing and localizing their pain and often believe that they have a constant yeast infection. Other symptoms include constant irritation, a raw sensation, the feeling of grating or sandpaper, the sensation of continual swelling, or the feeling as if they're sitting on a hard ball or not. The treatment of vulvodynia involves addressing several angles. One aspect involves avoiding environmental irritants. There are also several medications or oral pills used to treat nerve pain that we use. One of the biggest areas of treatment of vulvodynia involve pelvic floor physical therapy and biofeedback. Hypertonicity of the pelvic floor occurs when we have tensed up the muscles in response to pain, such that the natural resting state of the pelvic floor muscles is very tight and tense. This chronic state of tight muscles irritates the nerves running in the pelvis, causing the nerve endings that end in the vulva to be painful. The underlying problem is usually not the spot that it hurts at the vulva. The central goal of vulvodynia treatment is to retrain the pelvic floor muscles to relax. Is there treatment for post-hysterectomy lack of libido? If I poll all patients who walk through my door, 40 to 45% will report that they have sexual dysfunctions or concerns. And for 90% of them, decreased libido is the issue. I try to educate my patients that most women in a long-term relationship with a busy workload and family responsibilities don't have a natural, strong desire for sexual intercourse more than about 1 week out of the month, usually the week of ovulation. Most of my patients who had no libido issues pre-hysterectomy and then have decreased libido after hysterectomy usually had their ovaries removed. This is why I rarely remove ovaries that are healthy at the time of hysterectomy in women of any age, especially under 65 years old. For men, it's much more simple, because if they have an erection, usually they have a libido. For women, there are many more factors that affect their libido depending on what's going on in life at the time. Relationship factors include things such as how new and exciting is the relationship, How much nurturing and affection are you getting outside of the bedroom? Are you attracted to your partner? Do you feel your partner is attracted to you? Hormones also play a huge role in libido, especially for women who have had their ovaries surgically removed at hysterectomy or medically shut down from chemotherapy or Lupron. This is a more acute hormonal shock to a woman's system than natural menopause. I try to create the hormonal milieu of ovulation, and this usually involves estrogen and testosterone. Vaginal estrogen, in addition to systemic estrogen, is often needed to enhance the total experience. If a woman's hormones are okay, then adding more or trying to adjust usually adds little to improve her libido. Unfortunately, we're all searching for a magic answer, and many companies are making millions of dollars off women's search to find the magic potion. A big part of libido for women is our state of mind. This does not mean that libido problems are, quote, in your head, but as women, our biggest sex organ is our brain or mind. The role that work and money stressors and anxiety and depression and raising kids and family stress and medical problems play is enormous. Women can do some self-assessments by doing some internal observations to see what they think is going on. Most of my patients can start telling me things that are on their mind taking priority over sexuality that provides some insight into what may be going on. When the medical and hormonal issues have been fully addressed, many women benefit from meeting with a sex therapist to start tackling these issues, to come up with ways to promote sexuality on the priority list. There are licensed, certified sex therapists in most major cities whose client is your sex life. While not enough women are able and willing to see a sex therapist, this is where many women find a big solution to their libido issues. Another thing I stress to all my patients is to educate their male partners. Men and women are wired very differently. Most men cannot fathom that women really don't think or care about sex as much as they do. Men are often thinking, well, if you don't want sex with me, then who do you want it with, or who are you having sex with? Reassure your partner that you are interested in him, but just not always interested in sex. Since my hysterectomy, my big O is missing. Orgasm is the release of sexual buildup in the form of rhythmic, pelvic, vaginal, perianal, and uterine muscle contractions that's usually pleasurable. After hysterectomy, the uterus is removed, so the uterine component of orgasm is not there. Most women still achieve orgasm, but it may feel different or less intense without the uterus. Many women and partners do not realize that women achieve orgasm through clitoral stimulation, not so much vaginal penetration and thrusting. When women experience orgasm through vaginal penetration, it's usually because of the indirect clitoral stimulation. Even if the ability to achieve orgasm is lost initially after hysterectomy, most women who undergo hysterectomy for benign indications are able to achieve orgasm with time. It may take several months. Because pelvic prolapse and incontinence often has neuromuscular component to the cause for the problems, the surgery to repair can involve more disruption of the muscles and nerves in the pelvis, which can contribute to more post-op orgasmic issues. Again, with time, most women are able to resume orgasm. Once a woman has recovered from the initial post-op healing from hysterectomy, the biggest factor in the vaginal and clitoral sensory changes is whether or not the ovaries were removed. The vaginal, perineal, clitoral changes are delayed compared to the systemic symptoms of hot flashes and insomnia and mood changes that occur immediately post-operative with the loss of hormones. To increase the vaginal sensation, the treatment involves local vaginal estrogen therapy as well as topical testosterone in most cases. Since my hysterectomy, I feel sexually defective. Where do I start to find the answers to the old me? Sexual dysfunction after a hysterectomy is usually related to underlying specific issues. Women who strongly associate their femininity with their reproductive potential can have psychosexual issues to work through. There's a lot more emotion tied to your uterus than there is to your gallbladder or appendix. Also, when women have hysterectomy for cancer, they can have more post-hysterectomy sexual issues because of the emotional baggage that accompanies the reason for the hysterectomy. They didn't really have any choice in the hysterectomy. Many women who undergo hysterectomy for benign reasons and are choosing hysterectomy to fix a problem such as fibroids or pelvic pain or bleeding often report improved sexual experiences after hysterectomy. The biggest factor in post-hysterectomy sexual dysfunction in my practice is dependent on whether or not the ovaries were removed. This is why I rarely remove healthy ovaries and take them, just because I'm there, before the age of 65 years old. When ovaries are removed, especially premenopausal, there is a sudden drastic loss of hormones that start the snowball of post-surgical angst. It's less pronounced for the postmenopausal women, but there's still testosterone that's lost. In my experience, women after surgery with ovaries removed benefit the most dramatically from estrogen and testosterone therapy. Sometimes it's just giving yourself more time to heal physically and try to express your feelings over the sense of loss you're experiencing. It's like grief over any other loss, in that you may feel sadness and anger, but with time, most women move to a position of acceptance, where most days they don't dwell on the removal of their reproductive organs, but rather are glad to be rid of the problems they were having. I hope this gives you some insight into some of the sexual problems that many women face, and while there's no magic fix, there is help for most issues. You should talk to your doctor about the problems and concerns you face.